Recording in progress.
I think that's all, Dr. Penn. 26.
Okay. Excellent. Thank you. Well, welcome everyone. Let's see here. Pardon me while I am still adjusting my screen a bit. Excellent. Welcome everyone. This is, I forget where we're at, maybe our 7th webinar. Remember, again, we had to cancel our 2020 conference, and so we are grateful to all of our presenters for being willing to present via a webinar format. And I'm going to share my screen. I'm going to begin with our usual, which is to just simply review the presentation, our presenters, and then just a little Zoom etiquette. So today we have building collaborative partnerships among rural psychology internship training programs. We have Dr. Robin Hess, Dr. Claudia Canales.
Audio conferencing center. Please enter a conference ID followed by pound.
Please mute.
Thank you. Are you able to put them on mute? I can't actually see who that
I'm
is.
afraid if I put them all on mute, I'll
Now
mute.
joining.
Okay, I got it. Thank you. So, and Dr. Alyssa Gilden. So to Zoom etiquette here, just a reminder that it is a meeting, and so all participants are muted. If you can keep yourself muted, please use speaker view, so that allows you to see who is speaking. If you need to use view captions, excuse me, please do select the closed caption on your Zoom toolbar. We also encourage the use of the chat box for questions and comments during the presentation. APIC will be moderating the chat, and we especially do encourage you to participate if prompted by the presenters. Also, we ask that you save your questions for the end. There will be time for Q&A. And if you do choose to speak, please remember to unmute yourself and turn your video on. And lastly, the webinar is being recorded and it will be available on our website to view later. Also, the presenters have made their slides available, and that will be also available on our website. And if you did register, you will receive an email to complete the evaluation to obtain CE credit. We do have a new registration system. And so what we learned is that the link that you receive when you register is uniquely tied to you. And so I shared the link with a couple of folks, and now they're showing up as Mary Mendoza as well. So there might be multiple Marys in the room, but we learned that. And so moving forward, we'll have you register on your own. And then Dr. Jeff Baker, the Executive Director of APIC, and myself will be moderating the chat. And these are the learning objectives. The presenters will also be reviewing this during their presentation. Oh, and I should note that the presentation will go for an hour, so we will end at the top of the hour. And lastly, again, we have Dr. Robin Hess, Dr. Alyssa Gilden, and Dr. Claudia Canales. So with that, thank you all for being here. We are grateful to you. And I'm going to pull up your slides now. Okay, here we go.
All right, well, good afternoon, everyone. I'm so glad you could be here to join us. And so there will be 3 of us speaking today, and the way we've divided it up is just in three sections. And so my name is Robin Hess, and I am the High Plains Psychology Internship Consortium Training Director. And we are a consortium, so we have a few different locations, but our hub is in Greeley because that's where I'm at. We also have Dr. Claudia Canales, who's at the Salina Regional Health Center in Salina, Kansas, and Alyssa Gilden, who is with Clover Educational Consulting Group. And again, we'll be talking about how to build collaborative partnerships in rural psychology internship training programs. So next slide. And our goals for today, you saw the objectives from earlier, and so our goals really map onto those. One, we just, provide the context of what it is to provide to address the mental health needs in rural areas, and just to really highlight what those needs are and how to deliver in the context of having limited resources. That will be the first section of our presentation today. Our second section or goal for today is to review the benefits and challenges that go along with creating these training programs in rural areas. And then finally, we want to introduce different innovative strategies for collaborating among training programs. So collaboration within the rural areas as well as between different training programs in rural areas. Next slide. So one of the things I really want to start off with is this notion of what is rural. And I think sometimes there's the thought that it's, the big wheat fields, the waving grains of wheat, whatnot. But it's really very complex to say what is a rural community and what is a frontier community, which is an even more sparsely populated area. The US Census defines urban and urban clusters, but when it comes to rural, they just pretty much say if it's not urban and it's not an urban cluster, then it must be rural. And so that takes in lots of different kinds of territory that, for example, some of our most rural areas can be in Alaska and Hawaii. And so that might mean that there are these communities that you can only reach reach efficiently through flying into them or boat, crossing a bay to get to a very isolated village, for example. In Colorado, some of our largest rural areas are up in the mountains. And then obviously we have the big plains that I mentioned at the beginning where you may just have vast distances. It may be 2.5 hours to the nearest community. One of the things that we have started to do, because there are different ways that rural can look, is to really consider, well, how close is that next door community? So that you can have really tiny towns, but that are right outside a large urban area. So then we started really looking at rural counties and saying, well, what is the percentage of people living in these rural areas? And so when we start looking at frontier, we're saying there's 2 people per square mile. The population density, is less than 2 people per square mile. And these designations are important because different kinds of, depending where you're located, you can qualify for different funding opportunities, for example, through HRSA grants. So I think go ahead to the next slide. So just again, thinking about what it means is really a lack of, not a lack of population, but limited population and then limited resources in those areas. And over time, our population has really shifted. So back in 1910, for example, 54% of the population was considered to be rural. And today that population is down to 19%. However, 75% of counties in the United States are rural. So we really are clustering into those urban areas and then leaving many of our counties as qualifying in that as rural communities or rural counties. And most of those are concentrated in the southeastern United States. For the, let's see, I'm with High Plains, and so we serve more western states except for Nebraska, and only about 10% of the total population in the western region live in rural areas. Next slide. One of the things we do know about rural populations is that there are some unique problems that I wouldn't say they're only in rural areas, but that may be overlooked, that we maybe don't pay enough attention or assume that they're only problems of urban areas, when actually they can also be a part of what is the context of being in a rural community. So unfortunately, with the change from less of an agricultural community we have higher unemployment rates in rural areas. And so obviously with more unemployment, we have people who leave the community. So sometimes the communities are shrinking, or we have just the problems that come with not having employment, which is poverty. And so certain pockets of rural communities will have really high levels of poverty, which then we know can be associated with other kinds of problems. They're typically, not typically, but often there can be lower educational levels just because of opportunity and access. I mentioned this earlier that as communities begin to shrink and have fewer employment opportunities, then you'll see this outmigration of youth. And so then what goes along with that is some of the earning power of employees coming in who are making more money and, you know, buying services, buying homes. All of that begins to start to ratchet down and to decrease, and there's just less money coming into a community. And so then what begins to happen is the infrastructure of the community can begin to, I use the word erode here, but there's just less money coming in to support those services. And so very real outcome of this has been the closing of many rural healthcare centers and hospitals, which, you know, obviously during the pandemic was incredibly difficult for these small communities, as they no longer could count on healthcare being nearby. There, in some communities, especially, so I live in Colorado, so we have a fairly high suicide rate, as does our neighboring state to the north, Wyoming. And so that can be a problem of rural areas, a lot of it having to do with lack of access, but also distance to healthcare and some of these other issues that are going on in the community. And unfortunately, more recently, seeing higher levels of substance use and abuse in these communities, opioids, meth. So again, not all is bad in rural communities, but it's just important to remember that there can be these underlying issues in rural communities, which really makes how important it is to have mental health services available. So next slide. And there's been quite a bit of research on this one that really demonstrates the shortages of mental health service providers across the country in general, but especially in rural areas. So again, this particular GAM study, it's a little bit older now, but said that, you know, maybe 5% of metro counties would lack mental health services, but non-metro areas, rural areas, would have 20% of these areas lacking any kind of mental health service providers. And again, 85% of the 1,669 designated mental health shortage areas are in rural areas or rural communities. I just wanted to highlight this resource if you haven't gone there and you're curious about looking up your state. That you can look at the ratio of psychologists who are available in, or who are licensed in a particular state, and then look at mental health indicators. And one thing that we see is that counties that have a better ratio of psychologists available to the population tend to have better mental health outcomes. So next slide. So this map really just highlights, again, that health professional shortage areas. And it's, again, it's calculated by looking at the ratio between the population and the number of service providers. And so this one is specific to mental health services. And the darker the blue, the greater the mismatch between the population and the providers. So you can look at Nevada, for example, and New Mexico, and see how dark most of those states are, which is suggesting that there's just very few services available, mental health services available, and they become higher priority areas. High Plains, again, I'm the program that I am the training director for. We cover Wyoming, Western Nebraska, and Colorado. And again, you can see that those are shortage areas as well. And then we also, Dr. Canales will talk about Kansas. And again, you see that that's not quite the darkest blue, but it's a fairly dark blue. So again, these are all areas that are really high priority for services. Next slide. This is just another way of looking at these data. So these are maps from the APA workforce analysis that I talked about earlier, and they show the number of licensed psychologists relative to the population. And in this case, the lighter colors show the greatest disparity between population and psychologists. And just as an example, going back to Kansas, is out of the 105 counties, 101 are in mental health professional shortage areas. And so that calculates out to 96.19% of the state considered being severely understaffed to address the mental health needs of the population. And again, looking at Wyoming, for example, they have 62.85 psychologists to 100,000 people. So again, really, really understaffed when it comes to mental health services. Next slide. Okay, so yeah, that's just to give you that context of what is the issue, what is the concern here, and it's that we know there are important needs in rural communities, and then there's this incredible shortage that is just very acutely felt in these rural communities. Some other things that I think are unique and begin to start moving us toward why do training in these rural areas besides just looking at the shortage is of the wonderful opportunities that training in rural areas can provide to our interns, our psychology interns who come to these areas. There is a lot of diversity within some rural communities. For example, in Nebraska, I have interns who will be working with Native American populations, which really is an opportunity that they haven't had yet. There's the culture of rural that individuals are able to work with. One of my areas of interest is working with refugee populations who have begun to engage in kind of secondary migration patterns that will take them out to rural communities where there's opportunities for employment and the cost of living is less than in the big urban areas. So I think just, again, rural practice can have a lot of diversity, and because there are such limited resources that interns get to see a wide variety of clientele. Unfortunately, on the other side of that is there can be some difficulties associated with being a mental health provider in rural areas, that sometimes being able to enter into the community and gain the trust of the population can be a little bit more difficult. There's just not as many opportunities to work with people who haven't been members of the community for years. And so then new people coming in and wanting to deliver mental health services can be met with maybe some distrust. I think also sometimes in rural areas, we still have the stigma of, pull yourself up by your bootstraps type thinking, and really encouraging people that it is okay to reach out for help if you're struggling with mental health issues. So not only is there a shortage of the mental health service providers, but then our resources. For example, in Western Nebraska, if a juvenile needs a hospital, needs to be hospitalized, they have to be transported clear across the state to find a bed. And so it really, you have to get creative in how services are delivered because of those shortages and other kinds of services that you might need to access as a mental health provider. And then again, lack of health insurance is a concern. Next slide. This is something I'm working with my interns right now, is this whole, you want to have collaboration because that's really important within rural areas, but then also there's lots of levels of relationship. So you have to be very careful that you're not breaching confidentiality or creating a dual relationship when working in rural areas. I think in building supports or having rotations for interns, there's fewer agencies with resources to create and operate training programs. And obviously fewer psychologists to provide supervision. And then just in general, and I've already talked a little bit about this, there are these historical, social, and familial roots. And so being an outsider can sometimes be hard to, it can be harder to integrate into the community and build relationship with the community members such that they see you as a source of support. Next slide. And I really like this slide too. That was created by, oh gosh, I'm blanking on her first name, but Jackson, and really summarized what some of these barriers are as the 5 A's. So availability, just does the service exist? Accessibility, how easy is it or convenient to access it? And here again, we get into those issues of distance. It might be about pay, it might be about, again, just distance you have to drive to get to that service. Affordability, that one definitely is about the financial viability of somebody being able to access a service provider and be able to have ongoing treatment. And then the appropriateness. So are the services appropriate to the needs of the community? And acceptability. Again, the degree to which the services are meeting the cultural beliefs, values, and worldview of the community. So all of these can be another way of framing what some of the barriers to treatment are in rural communities. And so with our next slide, we're going to switch over to Dr. Claudia Canales, who also has a training program in a rural area. And she's going to talk about what are some of the unique challenges there.
Thank you, Robin. Can you all hear me okay? Yeah?
Yes.
Okay, perfect. So yeah, my name is Dr. Claudia Canales. I am here representing Salina Regional Health Center, which is in Kansas. I'm the director here of an internship program, and we are not a consortium, but we're affiliated with a medical hospital, a nonprofit medical hospital. So a lot of what I'll talk about will reflect a little bit of that. But we thought that we wanted to make a space to talk about the problems that we see even prior to internship, because you see internship is just 1 year. And the problems that we've encountered that come prior to internship is, of course, graduate school. So this slide is mainly about that. Within the challenges area, we find out that rural mental health has been largely neglected from higher education curriculums in graduate programs. We see this, it's very evident sometimes in internship application process where many of the applicants come from urban settings, trying to get the type of experience, but are not really familiar with rural living or rural subcultures and cultures unless they were raised in a rural area. But even having been raised doesn't mean that you understand the professional aspects that are involved within this. Then there are not as many, like it's training programs in rural areas, they're just not as many in general. So we have found a limited amount of resources being given to rural training, and then just attention. So I wanted to say also, to give like the little hope on the other side, the ideas that are currently involved in improving this has to do with creating curriculums that will take into account rural behavioral health. Garrett Evans, for example, who leads the National Rural Behavioral Health Center at the University of Florida, believes that other people will increasingly emulate his programs, which offer a rural curriculum and a 2-course sequence in rural behavioral health to clinical psychology PhD or PsyD candidates in the University Department of Clinical and Health Psychology. A few programs are starting to add didactic elements focused on rural practice and placements for students in rural areas. So even creating a little bit more of awareness and accessibility to like practicums or advanced clerkships in rural areas, sometimes summer internships. That's some other initiative that people have started to take place that we see that would be increasingly and very, very helpful as the applicants arrive to internship for the year. And that would decrease this lack of exposure of rural mental health once they get to internship. So next slide, please. And then we wanted to give you like a sense of a very typical story that may happen in a rural setting with us. So I'll just read it and then I will talk a little bit about it. So Paul Jonas is an intern in a rural site in Kansas. His site serves 15 counties and is located in the biggest city among these counties. There are around 45,000 people in his city, and yet Paul encounters many of his clients in the store and some restaurants by chance. Some of his clients like to stop him and want to catch up whenever they see him, while others feel very uncomfortable and try to walk away as soon as possible. In the time he has been in grad school, Paul has always sought out therapy for his own personal growth. But currently, every provider within his network, which is 2 other psychologists and 10 master level therapists, live in the same surrounding cities and work collaboratively with Paul. He does not really have options when it comes to finding a provider that can be covered under his insurance, unless he ventures to find someone 1.5 or 2.5 hours away. So this is just a snapshot of a reality that many interns may face when coming to a rural site. And this one in particular, of course, has to do with Kansas. So a couple of the things that I wanted to highlight is the fact that interns that are not familiar with rural living, rural subcultures, and professional workings within rural cultures will certainly experience a professional cultural shock, but cannot be dealt with adequately during the internship year alone. And it may affect their performance, it may affect the type of experience that they may get if we're not paying attention. Especially, internship orientation time is fairly small and you're trying to provide them with as much knowledge about your site as possible so that they can be successful. So the cultural aspects are definitely embedded within that, but nonetheless are not sufficient. Second, and probably a big part of the shock has to do with adjusting to different thresholds of boundaries and ethics. Robin talked a little bit about that, Dr. Hess, earlier on, and that these ethics and boundaries are not put into the test usually before they come in to rural living. And then it can become very interesting because the visibility of interns in some of these rural areas is very high, and the expectations for some interns to take on multiple roles outside their professional role within the site. Like here, you can be part of the school board if you want to, and be able to engage in community conversations about important decisions making, like right now, being able to vote for and against mask mandates that has become so politicized, things like that. Interns can become part of the conversation, or training police departments on different things can become expectations that all of a sudden you're just invited and given the opportunity to do, which is an excellent professional growth opportunity. And it makes you really visible and adds an added stress that otherwise you may not have. Let's see. Third is Paul's close and limited circle of peers and colleagues. We'll talk a little bit more about that, but I think you've gotten a sense already from what Dr. Setz has talked about. In contrast to bigger cities where conference and workshops take place within a drive, Paul will likely want to expand efforts and options for consultation and professional support. We'll address the questions probably a little later, but I think I saw a question about telehealth services, and that has absolutely, and we'll talk a little bit more about that later, that has absolutely been helpful, and I think will continue to be helpful. Nonetheless, if I guess I want to highlight the potential sense of isolation professionally and personally that can happen for interns. And this sense of isolation may be felt in a more personal way by Paul's limitations in finding a provider himself. The fact that his site insurance doesn't cover for out-of-network providers, and all the providers that he would want to see are considered out-of-network because everyone he works with are in-network and are people he works with. So there will be a conflict, of course. Next slide. So a couple of these are several training challenges that have been outlined also by the literature and that we find it to be true within our sites and what we've seen. Lack of training that can meet the diverse demand. Dr. has talked a lot or a little bit about the diverse demand that we can see. Rural psychologists are met with a full spectrum of psychological needs in addition to limited services and limited peers and limited specialized colleagues, creating a pressure to be able to provide with adequate and current care to offer some relief to the struggling population. Barbopoulos and Clark in 2003 highlighted that rural settings lack a specialized service such as speech and language specialists, women's shelters, programs for the elderly, rural childcare settings. So you can imagine what it's like to provide services when you are pulled to do a little bit more and just to make the services adequate enough for the population you're working with. Outside from the services that may be lacking, there is a sense in which rural psychologists are called to be generalists. So having a vast knowledge in multiple or every area of mental health possible without the option of really specializing because the need is so great. Then point two, the lack of colleagues available to consult unique and demanding cases. That is something Dr. Hesse spoke about, so I'll skip that one. Number three is difficulties acculturating to role mentality and stressors. I think that's also something Dr. has tapped on, but I just wanted to add one point. There are higher level of unemployment and substance abuse, as we talked about, financial crisis due to farming dilemmas that is very much felt in Kansas. So acculturating interns into knowing factors that are unpredictable, such as the weather factors, drought, floods, tornadoes, or even the simple harvest time versus non-harvest time, how like people mobilize themselves and think about their life within those times is super important in rural areas, very much felt in Kansas. Interns must adjust to educating clients early on the seeking help because of the self-reliance felt. And then I wanted to also put a note or highlight the fact that rural culture does not capture the subgroups or the sub cultures that are within rural living. So it's really important to know which side you are part of, and the subculture that is rural that may not be part of the greater umbrella. There are vast difference between different rural sites and settings. So it's important to know that as we move forward. And then limited privacy is not uncommon. This is something that I found really interesting, but it's definitely not uncommon for psychologists who have families and have children that are able to attend to school, for example, to have clients whose children are also in the same school. And so that creates, again, another little snapshot, potential for different ethical dilemmas and being able to keep some privacy for yourself, but also definitely respecting the privacy of your clients and their confidentiality. Next slide, please. There is a lack of training in collaborative and integrative models. The reality of rural setting involve high need for collaboration with multiple providers, as Dr. Hess had mentioned earlier. There is a high need to explain what the expectations are and the challenges embedded in collaboration. One of the greater challenges is that in medical shortage areas, everyone is trying to do as much as possible to provide the services needed. So education and partnering may take a second row because it requires time, effort, loss of income that would rather be met with providing services. However, just to give you a little snapshot, in an article published in 2019 by the Journal of Clinical Psychology in Medical Setting, noted that medical residents did not discuss mental health concerns when these were the primary complaint nearly 20% of the time, which suggests an urgent need for further communication and collaboration, and the knowledge on how to navigate this being psychologist trainees. And then point 6, other mental health professionals like social workers and many master level therapists have a different eye view or perspective in how to do treatment. So it's important to develop the type of training that learns to value both sides. So educating on the value that psychologists offer, as well as learning from the other mental health professionals how we can better partner up. The literature recommends adopting a bi-directional model of sharing knowledge and expertise and an egalitarian approach for the benefit of the client. Next slide, please. Oh, just kidding. Past the slide. I missed 2 points. I wanted to talk about just the lack of research support. And I think that also can be under the idea that the need is overwhelming for services, as I see it, particularly on my site. So research support will take a second row, sometimes third or fourth, in implementing any kind of program evaluation or research initiative, unless you partner up with a university. So that is very much felt. And then this is a training challenge, but it feels more like a practical. So I think maybe it will be talked about within the practical challenge, but I wanted to mention the limited opportunities for cultural and recreational activities can be very much felt by interns, and it affects the way that they then take in the training. So next slide. All right, and I think Dr. Hess will take it from here again.
Yeah, so some of the practical challenges we've found, and as Claudia and I have discussed, both of our training programs, is one, finding housing for people can be difficult in these small communities. Especially like if they have pets or something like that. That's where we found our struggle. In the vignette that Claudia or Dr. Canales presented, finding professional support. And yes, absolutely, during the time of COVID, when emergency telehealth services allowed for cross-state practice, that really helped our interns that they could still access their previous care provider. But otherwise, there are challenges in having that separation between who you're working with professionally and who you might want to get support from. We've also found childcare and transportation challenges can be present for interns. And next slide. And then sustainability challenges. And I'm going to go over these quickly because our next presenter is really going to talk about what are some things we can do that really help create sustainability for either partnerships, consortia, training programs, the integrated care settings that is more specific to Dr. Canales' site. So some of these challenges are really, as time goes on, really keeping our administrators invested in training programs. We recognize that there can be a lot of transition in leadership as people move on to new opportunities. And so we might have one group that was really invested in starting a training program, and then a new person comes in and maybe is less so. Also, and this was something Dr. Canales shared with me that I hadn't been aware of, is so some individuals are working in rural areas with for example, on those loan forgiveness programs through the National Core. And when their term is up, they will leave, and that creates a little bit more turnover than you might expect in a rural community or a rural area. And then, it just, each year, because of this turnover, it leads to putting a lot of effort into advocating with other members, like the social workers, the HR personnel, about having interns on site, what that means, how to support them, that there is a lot of that advocating for the role of the training program in these settings. And I think with our next slide, we transition to Dr. Alyssa Gilden.
I think it's still you, Rob. Do you want me to talk about this slide?
Sure. Sorry, I forget which, was this me or you? I apologize.
I think it was you, but I'm happy to chat.
I'll let you do it.
Okay. So we've talked a lot about training, and I'm here to talk about some innovative solutions and creative solutions for supporting training programs in rural areas. And it might take a little bit of research. Some of the things on these screens is looking toward like-minded organizations in your area or other agencies who are interested in working with some of the wonderful services that interns can provide. Interns bring in, and postdocs bring in, such creative energy and ideas from various places. And so finding a way to partner with other organizations in your areas in order to kind of share that energy and also bring resources from them. I'm going to talk a little bit about peer networks, which is the last bullet point on here, but finding ways to make sure you as trainers are connected and supported, and also that your interns and your postdocs, your trainees are also connected and supported. Next slide. All right, so just for a second, who I am and what I do. So my name is Alyssa Gilden. I work for Clover Educational Consulting Group. I am not a training director, but I am a senior staff consultant with Clover, and we've got our mission here on the screen and a bunch of things that we do. I'm going to go quickly to it, but one of our key focuses is development and accreditation of training programs to address so many of these things that Robin and Claudia have mentioned. There are challenges and also such benefits to providing trainings at every agency. And so that's just a big part of what we do. We're based in Texas. I'm in Austin. We have two bases in Austin and Mineola, Texas, so rural Northeast Texas. But we do work all over the country, and we work with programs all over the country, including Robin and Claudia. Next slide. Oh, that's an empty slide. Oh, just click through it. I didn't mean to have anything fancy on here. I'm so sorry. That's it. So I'm gonna only spend hopefully 30 seconds because I don't think you are the population I have to convince to have a training program, but training programs are such a valuable way to recruit and retain a workforce. And what it helps with, and the reason we at Clover do it as a part of our mission to improve the mental health of the community, is training program development and sustainable. It is a sustainable method to both increase the number of providers and the quality of providers in your area. And to be able to do so in a rural community allows those interns to receive the training in the culture of rural and in the area. And we know from research that interns tend to begin their career within 100 miles of where they train, so where they do their internship and where they do their postdocs. So when you can train them locally, you really can do a great job towards increasing the workforce in your community, which therefore increases access to providers. Next slide. Click through it again. I think this is the last slide that will have that. Hopefully. Oh, one further. Thank you. Sorry about that. So again, just talking about, I'll spend only another 30 seconds, but just the homegrown nature of the training and providing the training within the area, within the culture is such a valuable part and is what can make training really sustainable. And making sure you're well versed in the research out there so that you, if you're in a rural area, you can be advocating to your administration, because we did just talk about that as a challenge in terms of when there's turnover, having to say, this is who we are, this is what we do, and this is why this is a really valuable program to have here. And so, knowing that providers are well versed in the area, that retention rates of the population that you train can be really wonderful. And then I think one of the slides referenced there are funding programs available, a couple of different grant programs for accredited training programs. So it is a way that you could even bring money into the institution. Next slide. Awesome. Robin, do you want to pick back up here? Because this is
Yeah,
you.
this is.
I could talk about you, but.
So yeah, that was definitely a part of what our big mission was here, based on what we acknowledged were, some shortages in these rural areas, was this idea of how could we build partnerships. And so specific to my site was creating a training consortium with the help of Clover. And in this case, it was a university, a school district, community mental health, and a private practice, or two different private practices. And so what a consortium can do is a lot of that collaborative partnering that reduces the load on any one agency to be fully responsible for the training of interns. And so we, in thinking about what are some ways of delivering this kind of programming, we would advocate for consortia if having a single site seems too cumbersome for any one location. And again, I've talked about some of this material earlier of having this access to diverse population. And then there is the possibility of having some carefully planned rotations that can enrich the practice of the interns in the year they're there. It does take time to build capacity. And so we have been able to build in a few more sites, which has helped to, again, kind of spread that work across a lot of different agencies, so that when it comes to, for example, providing didactics, I have a network of agencies with practitioners, and then they have their networks, so we can call on them to help us in delivering didactics, or perhaps rotations, or having other supervisors when there's a specialized interest of an intern who can come, an individual who can come support that. We've also begun to invite other practitioners to attend some of our didactics, as again, building that capacity in the community. Next slide. This is my background is school psychology, so I'm going to do full disclosure here, is just if you are thinking about or looking at the possibility of building a consortium or creating a training program, is not to forget about school settings. That we were really lucky to find a few school districts that had licensed psychologists in them and become one of our sites. And then that allowed us to really build our outreach to children and adolescents that otherwise might not be seen, because the data really shows that a lot of kids get their mental health supports through school settings. It's also in going back to some of that stigma that we've talked about in rural communities. Schools are kind of trusted places, or at least there were in the past. They were trusted places in the community. Sometimes they're the biggest building in a community. And so a parent coming in or a child coming in to get support in a school is a lot less scary or stigmatizing than maybe having to go to the mental health center, or having your car parked in front of the psychologist's office. And so we can build on that relationship to then maybe help provide some support to children and families. And then also, when we make a referral to a setting where they could get more ongoing mental health supports, parents might be a little less resistant because it's from a trusted person who's making that referral. Next slide.
Robin, I'm going to suggest we move forward, if that's okay. Because
absolutely, I know I'm watching
today,
our time tick down.
Yeah,
and I think I've covered a lot of this.
Get to the exciting part.
Pardon me?
Go ahead.
Oh, I
Go
was
ahead.
just going to say, I think I've covered a lot of this. So next slide.
So consortium are absolute, oh, I forgot there was
more.
one more.
Go ahead, one more.
All right, perfect. So consortia are absolutely a wonderful way, but most of you already are probably here because your APIC membership are already running an internship training program, whether an individual or consortium. And so we also want to talk about another innovative strategy, which is GRIT, the Group for Rural Internship Training. This is a members-only professional network and resource hub that is a Clover administered organization. It was founded via a HRSA network grant, but we're gonna go ahead, perhaps 2 more slides to what GRIT is and what we do. So it's a supportive community. It's built to do a number of things, but these core offerings, you can stay right here. Thank you. This is what GRIT is. So GRIT offers consultation, and that includes both with Clover people who are versed in accreditation requirements and APIC criteria and those kinds of things, as well as a professional network and consultation with one another. So over this past year, we had a monthly faculty consultation group where we covered things like trainee challenges and due process and annual reporting online, and so many of those things that as training programs you're facing on top of so much of your day jobs and probably your own caseload and all of that, and having a network of other professionals who are facing the same kinds of questions can be really helpful. And maybe the trainee challenge is something that's a little sensitive, so you don't have a network within your own community, or it's not the right place for your consultation group or something. But GRIT, we really think that networking and consultation is an important thing for training programs. The other thing that can be really challenging if you have fewer providers in your area is didactic training. If you're at a hospital site with 40 psychologists and 100 NDs, it might be a little easier to fill a didactic calendar, but if you're somewhere with 2 psychologists, it is a little more challenging. So GRIT offered monthly intern didactics based on the 9 profession-wide competencies, so that you could, at least one part of the calendar might be filled. Clover is an APA sponsor of continuing education, so that's another benefit that we can offer through GRIT is continuing education opportunities for faculty. So that can just be challenging to come by. I probably don't have to say much more about CEs. And then also a recruitment tool. So this past year, we had a postdoc fair where programs that had postdoctoral fellowships and of course interns who are looking for postdoctoral fellowships could connect with one another, could learn about one another, and could learn about other training opportunities, continued training opportunities within rural settings. Again, that last bullet point is just a really big, I feel like I've connected, but really connection for interns, for faculty. It can be really isolating so many different parts of your identity to be training within a rural community. And so GRIT is a way that we have come together, and we have brought lots of programs together. Robin and Claudia are on our advisory committee in order to talk about what, these challenges and these benefits and come together. And of course, intern socialization, many programs, you may only have 2 interns where you are, or maybe you didn't fill your slots this year and you only have 1. And so having ways that interns can connect with one another and problem solve and ask questions and vent if they need to, and those kinds of things. Next slide. We'll skip this one. There's lots of benefits to GRIT, we think. We are on pause for the 21-22 year, but we will continue in 2022, and we're looking at a couple of different things, continuing to improve our continuing education. The other thing is so many programs have come to us and said, yeah, rural is really, really a part of our identity, but also so is integrated care, or so is, being in juvenile probation. And so one thing we may be looking at in the future is connecting across various identities of a training program, or various identities. Maybe consortia is where some of the specific questions lie. So those are some things we're looking at to the future. Go ahead. I will try to spend about 30 seconds on other solutions, and that is just to find other partnerships locally. So the state of Colorado, one of the universities, has kind of connected lots of different training directors and training opportunities together, and they come together a couple of times a year, or they email. The city of Houston has the Council of Houston Area Training Sites, I believe, which is all the APA accredited sites in Houston. Now, of course, Houston is a big city, so it has a number of APA accredited sites. But the interns come together a couple of times a year and do things like preparation for EPPP, or like how to approach that, the things that all of the interns are facing at the same time. So finding a way to make regional partnerships within your area. Chicago has a similar sort of training program organization. And then looking at the pipeline. So a lot of universities are either in rural areas and or have state funding that are interested in continuing, people educated in the university continuing there. So kind of looking and reaching out to universities and developing a pipeline, working, going into high schools and talking about psychology as a field. These are all important things towards developing a workforce, but I'm like running up against our time and I don't know if we have any questions. I think that is my last slide. We've got references in here too, so please look at those, but happy to open up for questions.
Thank you. Thank you to all three of you. The one question that did come up was with respect to the vignette, what about telehealth? And I think it was maybe Dr. Canales that referenced if there's anything more to say about that to answer that question.
I think Dr. Baker answered. I guess I'm not sure about the question. What about telehealth these days? How much is it allowed? As far as supervision or as far as collaboration? Or even
telehealth for the students, telehealth for the trainees.
For the intern.
Yeah, well, our site, and I think especially through the pandemic, there is a telesupervision, format that we can employ, and that has been super helpful. That is very possible. And same actually with, we advise our interns if they want to get any further training on anything, to be able to use those services adequately through telehealth and find supervision in the specialized perhaps training that they're looking. So it hasn't been a problem, and it is a great resource.
We have 2 minutes left. If anyone has any questions, feel free to put it in. Oh, there's a question. Look at that. I'm a DCT for Clinical Health Psychology Postdoctoral Fellowship Consortium in Florida. One of our sites is in a rural area. How do I join GRIT?
I have just put my email address in the chat, so feel free to email me. We'll talk about that again. It is on pause for the 21-22 year, though we do have resources available. Currently, all of our didactics are there.
Thank you for that. And I think yes, if you could all three put your emails in the chat, that might be helpful for everyone. And I just lost everybody. Here we go. Yeah, that way I know that we are out of time, but if folks do have questions, you can certainly contact our current speakers. And the slides have been made available on our website. So I did put the link to that in the chat as well. So thank you. All right, well, we are at my time, 2 o'clock. For some of you, I think 5 o'clock. The day has come to an end. And I certainly wish everyone a happy weekend. Thank you so much to Dr. Gilden, Dr. Canales, and Dr. Hess for presenting to us today. We are really grateful for your time and expertise.
Great.
Thank you.
Thank you so much.
Opportunity.
Welcome.